All right. Okay. Please,
Good
I hope
afternoon,
we are all
sir.
doing well. Okay. So, um, I think we. Okay. So I welcome you all to Pueriperium class. So basically, for this course, we are going to look at Pueriperium or the postnatal or the postpartum. So basically, as you've already started and you know the rules and regulations, so you don't on your mic, or you should always mute your mic so that you don't distract the class. And so please, kindly let's comfort ourselves. Okay, sorry, yes. So please, let's comport ourselves so that at least we can all benefit from the lecture or from the learning, because we are here to learn. Those of you who are fond of doing your own thing and you just want to disturb or want us to know that you are in class but you are not. Okay, thank you.
Elizabeth Francis, please mute it.
Okay, so please, I'm begging you that at least this is your second semester and I believe you've learned so much. So as much as we can, please let's make sure our mic is constantly off or is muted. So regularly, even if you are doing whatever, you are in the market or you are doing your own personal stuff, please kindly ensure that your mic is muted. Regularly check that your mic is muted. Otherwise, the next time I will not say mute your mic. I will just put you in the waiting room so that you can't be part of the class to disturb everybody. So please, let's take note at least for this time period, and basically for all the lectures that you have. Please ensure that you are actively present. Like last week, I told the other group that you are here to learn, and so make sure that you are here and you are actively present. Don't make yourself you've on, but then you are not actively present. You are just doing your own thing. At the end of the day, believe me, you don't hear anything. Though you hear that somebody is talking, but you don't benefit. So then why waste your data? Then I think it's better you don't waste your data. Just mute it and let's know that, or just go off and let's know that you are not there. Okay. And then the other important announcement I want to make is that please, for the course outline, I've shared with you through your course rep. But then for all lecture materials, for the lecture notes and everything, please, you have to access it via the V class. I'm not going to give any lecture notes or any material to your course rep. So you have to be able to access the V class so that you can have the chance to have, that is, the reading materials or the lecture notes. And so please, those of you who haven't registered, those of you who haven't registered, the academic, that is, the semester has started. So please make sure you register so that you can have access to the V class. And in case you are also having challenges with the V class, I'm sure there's a number that has been given. You can easily reach out so that you'll be able to access the V class, or you can get assistance or help from that place so that you'll be able to access the V class. And so please, sisters, this is very, very important, and I want you to take it very seriously. So from now, like I said, apart from the course outline that I've shared with you, any other information or any other lecture material concerning this course will be accessed via, or can only be accessed via the V class. And then also as part of our activities for the semester, or that is, as we go through the semester, we'll be doing some quizzes and the midterm. They all can be accessed through the V class. So it means that if you don't register, you cannot have access to the V class. And it means that basically you are not part of the class. That's what it means. And so please, sisters, let's take note of that. And then let's take this opportunity to register as soon as possible. All right, thank you. So like I said, if you have any concerns or any other thing, please reach out. I'm sure there's a number that has been given to you for assistance as far as your Zoom or your V class is concerned. Kindly reach out to that person, and they will provide you with assistance. Okay, so just a quick through that is our course, or our course that we'll be considering, our course outline. I just want to run us through, then we can start with our introduction or our first topic for today. Okay, so basically, like I said, we are in a Pueriperium class, and so the course we are considering for this semester is called Pueriperium. And basically, I believe that all of you here, at least you've passed through the diploma, and so at least you have a fair idea, or especially an advantage for those of you who are working, or those, that is, the clinicians who are working, and also the tutors, or yes. So that is like, just to say that we are not new. Okay, so just for you to know that at least we are not new to it. And so from time to time, as we go along, we'll be having discussions. Those of you with experiences, you can share with us and all that. And so I want the class to be interactive as possible, but much as I want it to be interactive, we will have time so that most part of that is throughout, that is during most part of the time when lecture is going on, that one, our mic is muted. But then when they get to the discussion, we can all unmute ourselves and contribute. All right. So the program here is CODeL. So in case that is BSc Midwifery CODeL. So in case maybe you are here and that's not the course you intended to do, it means that you've missed your way and you have to reach out for help. Okay, then the course code is MIDW 370, and it's going to be a 2-credit hour course. And we are in semester 2. So basically, so I'll be your lecturer, and my name is Dr. Georgina AFOAKWAH, and that's my email. So that's my official email. But please, before you send anything, just alert me first. Okay, so for a better understanding of this course, at least you should have a prerequisite knowledge in anatomy and physiology, which I believe you have, right? From the diploma level, and then even the first semester, I know you did something on APRS. And so it's very important so that especially the physiological aspect and then the anatomical aspect, like if you mention an anatomical aspect, you should be able to understand and appreciate where anatomically is being situated and then the physiological function of that organ. All right. So then at least you should have also done pregnancy and then labor, which you have done. And you are, I think this semester, you are only considering the abnormals. Okay, then newborn. But then with a newborn, we will consider the newborn as part of this course. So as part of this course, but I believe you've already started high risk neonate. So for the newborn, just the physiological adaptation of the extrauterine life will be considering as part of this course. But then, like I said, with a high risk neonate, I believe it's part of this semester's course, and I know you've started doing it. Okay, then we have pharmacology, which at least you need to understand some basic pharmacology and so that during puerperium, what medications and then the right drugs for the woman, that is the postpartum or the puerperal woman, and then biochemistry and then knowledge. So your knowledge in biochemistry and microbiology as well. So with the course description, this course is intended to provide you with a comprehensive knowledge and clinical competencies in the care of women, their newborns, and families during the puerperium. So basically, with the entire, that is considering what we call the puerperium, it comes in phases or it comes in stages, and we have immediate, early, and then late postpartum period. So we will look at it according to the phases or the stages that a woman goes through right after birth or right after delivery of the placenta. Then it also covers physiological changes, postnatal or postpartum assessment, breastfeeding support, counseling, mental health, prevention and management of postpartum complications, and community-based postnatal services. So this one, unfortunately, we will not dwell so much in it because we will do community midwifery, and so we will only touch the specific ones that is the puerperal woman, the newborn, and their families will need. Okay, and so emphasis will be placed on the quality, respectful maternity care. In fact, it's one of the principles as far as puerperium is concerned. And you know, for respectful maternity care, it runs across our care. That is a lot. That is it is we apply it during the antenatal, we apply it during the intrapartum or intranatal, and then postnatal too we have to ensure respectful or we do what we call respectful maternity care. So in our care, we include this, that is, we ensure that yes, we give or we provide the woman with a respectful, a care that is respectful. Okay. Hello, Gloria. Gloria Fari, your hand is up. Is there any issue or it's a mistake?
Dr. Georgina, please,
Yes.
this is Dixie, course rep. Please,
Okay.
last week you did the introduction with us.
Okay. You are the ones. Okay, okay. I thought, okay. Oh, that's okay. Oh, okay. That's fine. Thank you for letting me because okay, so I met you on all right. Then it was is the I think the other class. Okay.
Oh,
Thank you
okay.
so much. Yeah, thank you for at least you it's good that you've informed me on time. Okay. And I said last week, if we did it last week, I remember I even praised you guys. So what is happening today that some of you have started disturbing us? Because I was thinking maybe we couldn't meet. So we are meeting for the first time. So please, let's try as much as possible so that we can all benefit from. All right. Okay. So let me share the slides so that we continue. All right. Okay. So I believe you can see my slides now. Okay. All right. Okay. Thank you. So, yes. So let's continue. Yeah. So I remember we started with the introduction, and so let's continue, hopefully, to see if we can complete the anatomical and physiological changes so that we go ahead to look at sorry. Okay. Yes, so by considering the anatomical and physiological changes of the puerperium or of the puerperal woman, at least we've known the definitions and then we went through the stages as well. So with the anatomical and then the physiological changes, we are saying that almost every organ undergoes change during the puerperium. And I remember I also told you about always having the picture of the pregnant woman before you. So during pregnancy, we have pre-conception, so which is when the woman is not pregnant. That is where there's nothing, the woman is having her own natural or her own normal physiological processes going on and everything. And then pregnancy happens. And so the moment pregnancy happens, as you've been taking through pregnancy or normal pregnancy, all the physiological, there's a change in the physiological functions or adaptations. And so the body undergoes changes so as to accommodate or help with the developing fetus. So everything, the woman switches from her normal self to a self where is able to, or to an environment, the internal environment begins to work in a way that will suit the developing fetus and help it to grow and develop well. So here we comes the woman, our woman is now delivered, has given birth, and then after delivery, that is the fetus has come, the uterine content has come, and then the placenta too has come. And so everything is reversing back to its original state or to its pre-pregnancy or almost near the pre-pregnancy stage. So we are saying that all the organs undergo change during the puerperium because during the pregnancy as well, all the organs, almost all the organs in the body is being affected, even including the teeth or the dental, that is yes, the dental or the teeth of the woman, the eyes, everything becomes affected by the pregnancy. Okay, so basically is what I have explained. So all the systems, organs, and tissue that were affected during the pregnancy by the pregnancy hormones gradually return back to its normal state. So first of all, we are considering the changes that occur in the reproductive system, and we are saying that the reproductive system undergoes what we call evolution. So evolution simply means refer to the process. So actually, it's a process. So if we say a process, it's not like a sudden or a one-time thing. It's like it goes through phases or it goes through stages. So evolution is used to refer to the retrogressive changes taking place in all the organs and structures of the reproductive tract. And so that is basically what we refer to evolution. And so basically what happened is that evolution almost affects or mainly affect the reproductive system. So it mainly affects the reproductive system. We know that the reproductive system was the center or the central focus during pregnancy, because that is where the fetus is in the uterus and beginning to grow. And so the reproductive system becomes the focus, or where most of the changes occur. Okay, so considering the uterus, we are saying that yes, so involution occurs, and then by which the uterus does what? Returns to its pre-pregnancy size and condition after childbirth. So it's a remarkable physiological process involving what? A complex interplay of hormonal changes, tissue remodeling, and muscle contractions. So the uterus becomes firm and retracted with alternate hardening and softening. And so we say that it's supposed to be firm during the immediate phase. It's supposed to be firm and well contracting, so that if that is happening or if that is not happening, then we know that there is a complication, or there is, yes, a complication or something happening. Okay. And we are saying that typically it takes about, or on the average, it takes about 6 weeks, although complete involution at the cellular, that is at the cell level, may take longer. Okay, so let's see the stages of uterine involution. So we have the initial or the immediate postpartum. We consider the fundal height. So with the fundal height, we are saying that midpoint between the pubic symphysis and umbilicus. So immediately after delivery, so as soon as that is, yes, after delivery of the baby and that of the placenta, and then the uterine content. So if we are to measure that is the fundal height, we are saying that it's supposed to be midpoints between the pubic symphysis and umbilicus. So mostly we say that it's at the level of the umbilicus, or it look that is the uterus of the woman looks like when she is what, like a pregnant woman in her 26th week. So no, in her 26th month, sorry, in her 26th month, yes. And so, hey, sorry. What am I saying? No, in her 26 weeks, that's what I want to say. Yes. So that is what, in terms of we comparing it to the time she was pregnant, that is how we compare it to be. Okay, so in terms of the size and weight, we are saying approximately 1,000 grams. Then it also can contain 5 liters. 5 liters of volume. And then in terms of the size, we have 15 centimeters long by 10 centimeters wide by 7.5 centimeters thick. So when you take the uterus, that is how the measurement looks like. Okay, after or immediately, so this is the immediate part, immediately after delivery. Okay, sorry. Then we look at the shape and consistency. So we are saying that it's hard, that is immediately, or the initial state of the uterus after immediately following delivery. We're saying that it's hard, it's globular. So it's globular in shape, then similar to a cricket ball. So that is how it looks like. So this is as a result of the delivery of the fetus, the placenta, and amniotic fluid, along with the loss of hormonal stimulation. Okay, so once there's no more, once there is no more hormonal stimulation, this is how that is the uterus begins to feel like. Then we talk of the placental site. So we say that the placenta detaches, reducing the diameter of the placenta attachment site on the decidual from 18 centimeters to 9 centimeters. So it reduces by, let's say, like half of its size, or yes, half of its diameter as it was when it was attaches. Then we talk of the first 24 hours. So for the first 24 hours, still under the immediate postpartum, we are saying that fundal height remains relatively constant. So the uterus begins to shrink and becomes firmer. So by days, that is day 2 to 3, the fundal height decreases by approximately 1.25 centimeters or cm. So we normally say that 1 finger breadth every 24 hours or 1 finger breadth per day. All right. So as we continue, or yes, as the postpartum days continue, so by the end of week 1, which is the 7 days, uterus is typically no longer palpable above the pubic bone. And by the end of week 2, uterus descends into the pelvis and becomes a pelvic organ, because naturally that is where it's situated. So the uterus is a pelvic organ. So 6 weeks postpartum, we are saying that there's involution is complete. So generally, involution is complete. Uterus returns to approximately pre-pregnancy size, though complete involution may take longer. And as I've already explained, it may take longer because, at the cell level, and especially at where the placenta detaches. I always say that, that when the placenta detaches, it leaves like a wound. It's just that we don't see, but the size, if you deliver the placenta and you look at the size, how large the size is, then it tells you the wound, or yes, the wound that it has created within the uterus. And so sometimes it takes a longer time to actually heal and then return back to its original state. Okay, then with position, we are saying that it returns to an anteverted and anteflexed position. So basically, that is how the uterus is positioned, normally positioned in a pre, that is in a non-pregnancy state. So it returns to an anteverted and anteflexed position within the pelvis. And so by the end of week 2, we are saying, or by the time 6 weeks postpartum is completed, the size and weight is approximately 7.5 cm long by 5 cm wide by 2.5 cm thick. And it should be weighing 50 to 70 grams. And then in terms of the shape, we are saying that endometrium has significantly decreased in size. So once the endometrium, which is the inner lining, decreased in size, then everything shrinks back to its normal state. So quickly, let's look at the key mechanisms of uterine involution. So one, we have what we call the muscle contractions or the muscle contractions. And so this is where, as a midwife, as soon as you deliver the placenta, you need to ensure that the uterus is contracting well. Yes, the uterus is contracting well so that it doesn't lead to any PPH, or yes, any PPH, or you make sure that there's nothing being retained in utero. So with the muscles contractions, we say that immediately after the placenta is delivered, the uterine muscles begin to contract strongly. And then with the synthetic oxytocin also being given, it also helps with the contraction. So these contractions compress on the blood vessels, helping to control bleeding at the placental site. And so the blood vessels are obliterated by thrombosis and become degenerated, while its remnants are transformed into elastic tissues. So, and I don't want to go into detail so much, but I believe you learned during either pregnancy or APRS the moment the placenta is formed, new vessels are formed, right? There's new blood vessels that are formed. And so what happens is that these are there to help nourish that is to help the inflow and out of blood supply to the fetus and also out to the mother's circulation. And so what happens is that once the placenta is out, it's supposed to die, or it's supposed to I don't know how the best word to use, but they are not supposed to be there anymore because they are not needed. They are not needed. It's like their function is no more there. And so they begin to that is thrombosis, it begins to die. Or yes, thrombosis sets in, and then they begins to degenerate. Okay, so they are all part of what helps with the evolution of the uterus. And so here we are saying that the contractions also help to expel any remaining blood clots and tissue. So oxytocin, a hormone released during breastfeeding, plays a crucial role in stimulating these contractions. So apart from the synthetic oxytocin that is being given, what also happens is that the most important thing why we want to initiate breastfeeding within the first 30 minutes to 1 hour is to ensure that, naturally it helps, that is oxytocin is being increased. So what happened is that whilst after delivery, whilst the estrogen and then the progesterone is going down, it replaces or is replaced by the oxytocin and prolactin. And you know that one of the function of the estrogen, the oxytocin is to help with the contractions. And so the more we encourage the woman to put the baby to breast, the more contractions will occur. And so what happened is that the contractions, as we've just mentioned, I just mentioned, helps to what? To prevent bleeding. So it compresses on the blood vessels, helping to control bleeding at the placental site. All right. So the next mechanism we call it autolysis. Or well, you are doing pathology, so probably you should help me pronounce it well. So either autolysis or autolysis, well, however way you want to mention it. And the most important thing is that you understand that yes, that autolysis or autolysis is also part of the mechanism of uterine involution. So with the autolysis, what happens? So basically, the autolysis simply means self-destruction of excess uterine tissue. So it simply means self-destruction. So what happened is that this mechanism also sets in so that, with the decidua, there's this inner lining that is being formed during
Vanessa,
pregnancy, which
Vanessa,
is called,
who must
hey,
move to the pepper?
okay,
Who move to the pepper?
for waiting room. Why? Ah, Simone. And then the gift when they were for and then my team more in so my team marks in so.
Sister, catch your why? Ever sister.
And then the I say what they were pro for my team marks in so intimate more. They should help because the more they do this, it just distracts the class. Okay. All right, let's continue. So yeah, so we are still looking at the mechanism of autolysis as a way of helping what reduce or shrink the uterus back to its normal state. So you can see that it's not a simple job it undergoes because look at the height the uterus will go during term when the woman is at term, and then it will reduce. Sometimes for some women, you don't even, if they don't tell you that they've even given birth before, you wouldn't even believe that they've given birth. Like everything goes back to its normal state. But then there's also another, I don't know, but I believe we've observed it, and in fact, for most women, in fact, if you can get about, like, let's say, for every 5 women, you get about 3 women with big, I don't know whether it's as a result of the tummy or it's as a result of the uterus. So, well, I'm here to, I want to do a research on that to be sure what exactly, whether is hormonal effect or is it that the uterus didn't volute? I don't know. Well, I'm yet to, because I'm sure you've observed a lot, especially in our part of the world. For the for the white, it's difficult for you to see a white, or it's very rare, although we have also some of them with a big belly after delivery. I mean, after like about some years to come. But in our part of the world, whether it's the type of food that we eat or what, you will still see most women after delivery, we will be having this, you don't see the tummy, or yes, the tummy going down so well to its original state. Anyway, that one is for another day for us to talk about. All right, so let's go on. So yeah, so we are saying that self-destruction because there's supposed to be an environment that that is the uterus has assumed, especially the inner lining being replaced by the sidua. And so what happens is that it has to all break down and then come out as lochia. Okay, so we are saying that with the autolysis stage, okay, so it helps to destroy those excess uterine tissues. And so during pregnancy, yeah, so I've just explained that during pregnancy, because of the hypertrophy and then the hyplasia, there's an increase in what? In the number and then the size of cells of the uterus. Then also after birth, the body breaks down these extra cells, reducing the size and weight of the uterus. And so this process is facilitated by enzymes. And those enzymes are referred to as what? The lysosomes. The lysosomes helps with the breakdown and release within. So they are released within the uterine tissues. And so what happens that they are enzymes that helps facilitate this breakdown of this excess uterine tissues. Okay. And so yes, so basically, as autolysis occurs, it also helps reduce the size and then the number of uterine cells, because the woman don't need it again to be carrying it around after the delivery or after childbirth. Then let's look at then the next thing that also influence these that is the shrinkage of the uterus is also due to hormonal changes. I've already talked about the estrogen and then the progesterone, and so they helps with the stretching of the uterus to the extent that it can go even until the woman is term. And so during evolution process, after delivery, there is a decrease in these hormones. So estrogen and then the progesterone. So once its effect drops drastically. So what happens is that it helps trigger uterine involution. Once they are there, unfortunately, the uterus cannot involute or cannot contract to come back to its near its original state. And so, please, sisters, I will just advise that you need to understand the most important thing is that, so what was the estrogen doing? What was the progesterone doing? So what role were they playing? That this time, if they are decreasing, helping the uterine to involute. So, well, that is just a reading assignment, a personal reading assignment on your own, just to understand their role. And well, you just did pregnancy, and so I still expect you to know their functions. But anyway, let's continue. And so oxytocin, so the next one, as I just talked about with the oxytocin, is released during breastfeeding and also administered exogenously. That is like the synthetic one that I said, to stimulate powerful uterine contractions. So these contractions contribute to ischemia. So ischemia simply means that is when there's reduced blood flow within the uterine muscles, further promoting what we call catabolism or catabolism. Okay, and so the third one, as far as the mechanism of the uterine evolution is concerned, is the ischemia. So ischemia basically when there's there's lack of blood flow. So what happens is that with the ischemia of the myometrium that is caused by the continuous contraction and retraction of the uterine muscles after the expulsion of the placenta, compresses the blood vessels supplying the uterus, leading to a reduction in blood flow. And so this reduced blood flow contributes to the shrinking of the uterus and what helps prevent excessive bleeding. So the vast amount of blood which was contained within the uterus is pushed out into the bloodstream. So we call it autotransfusion. So what happens is that once the evolution continues or is occurring, what happens is that with some of the blood comes out as lochia, but then some also are being or returned back into the maternal stream. Some also return back into the maternal stream, and then later the woman will urinate. So that's why during the postpartum too, one other sign is that there's frequency of urination. So the woman begins to urinate a lot. So what happens is that this greatly increases the volume of fluid in circulation, which is removed by the kidneys, which leads to major diuresis in the early puerperium. So basically, what actually causes the early, there's increased diuresis or urination during puerperium is as a result of this, the autotransfusion of the maternal own blood. Okay. So the last but not the least has to do with the endometrium regeneration. So after it has gone through the contractions leading to what ischemia and then autolysis and all that, then it brings out these dead cells. So those dead cells has to come out as lochia, which very soon we will look at it. Yes, Augustina. Oh, it's a mistake. Okay, let's continue. So this has to come out as lochia. And then I've talked about, so as it does that, it's, the endometrium begins to regenerate, or new endometrium is being formed. So during puerperium, and let me complete this first. So as the new endometrium comes out, what happens is that it prepares the uterine lining, the uterine lining for subsequent pregnancy. So it does that in such a way that it's like no pregnancy has occurred, or pregnancy has not occurred, though it will not go to like its original state, but then because of the wear and tear, so definitely it will not go back to its original state where nothing had happened yet. But what happened is that there is a regeneration where it prepares the uterus again for subsequent pregnancies. So here we are saying that during puerperium, the endometrium regenerates except at the placental site, which heals by a process of exfoliation and scar formation. So it heals by the process of exfoliation. So that's why I said that it will not completely assume its original state where there hasn't or there has not been any pregnancy. So here I said, I note that during endometrium regeneration, the superficial part of the decidual is shed off with the placenta and membranes. Yes, with the placenta and the membranes that is continue to shed off as lochia. So let me explain. Okay, let me finish with this one, then I will explain. So with the basal layer of the decidual remains after delivery. Formation of the new endometrium takes place by the decidual basalis. Okay, so this is what is happening. So after the contractions causing autolysis and then ischemia and all that, where all those dead cells begins to come out as what? As lochia, in the form of lochia, urine, and all that. So afterwards, the endometrium begins to separate into two. So they separate into two parts or two phases. So we have the superficial part, and then we have the basal layer, or we have the superficial layer and then the basal layer. And so what happens is that the superficial layer is sloughed off. So it also comes out as part or is shed off as part of the lochia. Then it remains the basal. So like basically if you say basal, like the base, it's like you've scraped something off. For example, if you have a fertile ground, let's say you want to plant something and you have a fertile ground, and then maybe you just try to scrape the surface away so that the rich part where it has turned into black soil and all that can be seen. And that is where it's very rich. So the moment you put in any seed, it begins to germinate again. Yeah, so this is what happens. So the superficial layer part is also come out as lochia, but then it remains the basal layer. And what the basal layer does, that is where it then brings out the new endometrium. So the basal layer is like it germinates, let me in quote. So that one comes out and then it brings out what you call, or it forms a new basal endometrium. It forms a new endometrium. And so that is what happened. And like I said, as it forms a new endometrium, or it allows a new endometrium to come out, it then prepares for another pregnancy. Okay, so the entire endometrium is restored by the 16th day after delivery, except at the placental site, which takes like 6 weeks or longer. So I said that note that it is important to know that the uterus never returns to its initial pre-gravid state in terms of its size and weight, but with each pregnancy, the muscle weight and collagen content of the uterus is slightly increased, and elastin is deposited around the blood vessels. So that's why we have a multipara woman compared, which is in terms of her physiological state is different from that of a premipara woman, because definitely for the multiparous woman there has been a wear and tear, and the place begins to lose its elasticity. All right, so from there let's look at, so this is just an image just showing you the stages of evolution over the days as the days goes by. So let's look at lochia, because we are saying that those dead cells comes out as lochia. And so I also call it endometrial shedding. So the shedding of the endometrial that comes out as lochia. All right, and then with the lochia, we have three, or it changes over 3 phases. So I said the lochia changes in character over time. So we have the lochia rubra, the lochia serosa, and then the last one we'll look at is the lochia alba. Okay. So with the lochia rubra, as like I said, we are all not new to that age. So it's basically bright red, like a heavy menstrual flow containing blood, decidual tissue, and fetal membranes. So it lasts that is for about 3 to 4 days postpartum. The lochia serosa also is pinkish brown, and then or basically pinkish, because sometimes some textbooks or some books differ in terms of how they describe it, but basically it turns pinkish, or the bleeding becomes lighter compared to the lochia rubra, or compared to the rubra. Okay, so we are saying that with the pinkish brown, which is the lochia serosa, contains less blood and more serous fluid. And we can look at that between the 5th and 9th day postpartum to also change over. Okay. And then so it changed over to the lochia alba, which is whitish yellow or pale or creamy white, containing many leukocytes. So basically dead tissues, mucus, and epithelial cells. And for that one to by 10 to 15 days, or some consider it between 10 to 14 days. So between that period, it's supposed to stop, or it's supposed to almost, that is, the lochia is supposed to be over. Okay, so let me say, put it like the flow of the lochia, let me put it that way, is supposed to be over. Okay. All right, so with the lochia amount, so the amount and then the duration. So the average amount of lochia discharge during the first 5 to 6 days postpartum is estimated to be around 250 mils. So basically with the initial, that is bleeding, can be like 500 mils. But then subsequently, as it goes on, we are supposed to, an estimation of about 250 mils is okay. Yes, and then keep in mind this is an average and individual variation is expected. So with a normal duration, lochia can normally persist for up to 3 weeks postpartum. So by 3 weeks, the woman is supposed to be like, that is supposed to be drying up, or is supposed to be complete. Okay. So with the important considerations, yes, I said in terms of clinical monitoring, we also consider individual variations. So factors like parity, number of previous pregnancies, breastfeeding. If the woman is breastfeeding, the contractions become severe, and so there's more bleeding. And then the mode of delivery can also influence the amount and duration of lochia. And so maybe the question comes between CS and SVD. So which one do the woman experience the most bleeding? Yes, please, you can type your answer in the chat box. So between CS and SVD, in which one does the woman bleed more in terms of that is in terms of amount, as far as lochia is concerned? Okay, so yes, all right. Oh, okay. Oh, okay. So yes, so maybe it's no, it's CS. So mostly the amount of bleeding in CS, or in women who undergoes that is undergoing delivery by CS, is more heavier and than that of the SVD. Yes, and so for example, if we are recording like 500 mils of bleeding of blood from an SVD woman, we will record like almost like 1,000 in that of the woman who undergo CS. Yes, and so is CS. All right, thank you for your answers. All right, thank you. Okay, so we have what we call subjective assessment. So assessing the amount of lochia is often subjective. So normally, because the woman will use a pad, hey, Grace, okay, maybe first of all, anyway, somebody can help with the explanation. But then, Grace, I want you to also go and read it for yourself so that next week you come and teach us. But, well, if anyone can provide her with the answer, that's fine. But I want her to also go and read for herself. Okay, all right. So, yeah, so normally we use words, especially in our documentation, we use words like scant, light, moderate, or heavy. Because, like I said, the woman will be using a pad. And so sometimes in quantifying it, it becomes subjective. So we normally refer to, oh, maybe scanty bleeding or light bleeding or moderate bleeding or heavy bleeding. So basically, standardized visual aids or more objective measures like the weighing pad can improve accuracy anyway. So let's quickly look at, so as we are looking at what happens normally in lochia flow, we also want to look at any red flags. We also want to look at any red flags associated with the lochia or with the bleeding. So one, we have excessive bleeding. So the more the woman begins to saturate more than 1 pad per hour. So if, for example, if a woman after delivery is saturating more than 1 pad per hour, should be considered a red flag and investigated. Maybe there may be some tear that she is bleeding from, or maybe there may be a retained product of conception. So we need to be sure what is causing the bleeding. So we are saying that when the woman is saturating more than 1 pad per hour, should be considered a red flag. And then when there's also large clots, so passing large clots, example, larger than a golf ball, can indicate retained placental fragments or subinvolution. So subinvolution simply means when the uterus is not contracting well. So it's not contracting well as a result of retained product of conception, or maybe as a result of infection. Especially in those women who experiences early what do we call it? Like when the water breaks early. Yes, sorry that I'm missing it, but yes, when there's a prom, yes, then we need to end. We don't. Yes, prom. Yes. So when there's a prom and early intervention is not given, there can be an ascending infection. And so sometimes it also can be the result of the woman experiencing subinvolution. Okay, then a sudden increase in bleeding. So a sudden increase in lochia after it has been decreasing can also be a sign of a problem. So for example, we've looked at the stages. So changing from that is rubra to serosa and then to alba. So let's say the woman we've seen over the days, we've seen that the heavy bleeding has changed into the serosa. Then all of a sudden she's bleeding again. It's like there's red blood coming out again. Then we should immediately suspect a danger. Yes, so these are all red flags that should alert us that no, the woman is in danger, or the woman's life is in danger, or there's a problem that needs our immediate attention. Okay. Then yes, then foul odor. So a foul odor is a sign of potential infection. So here, patient education is very important about what to expect regarding lochia and when to seek medical attention. And I think, well, I know most of the time you do it just to help the woman before discharge, or as part of their discharge, education, where you teach the woman what, as she's going home, in terms of the bleeding, what she's supposed to expect, that's supposed to change from this to that at a certain stage or within how many days. And so the moment she realizes all these things, maybe large clot coming, excessive bleeding, she bleeding again after it has changed, there's an odor, then she should quickly, any of these, she should quickly report back to the clinic or to the facility. All right. So, okay. So here, basically, factors influence endometrial regeneration, or yes, so that influence it either negatively or positively. So basically, I've put together breastfeeding, which we've already looked at before, and then infection, endometritis, retained placenta of tissues can all cause or result in or affect the endometrial regeneration. So sometimes that's why somebody can give birth to the first child, and then you can see that subsequently she will try and try and try. Subsequent pregnancies may not be coming. So that's why they need to attend postnatal care, that is postnatal clinic, for examination, so that the womb can be prepared for subsequent pregnancies. Okay. So let's quickly look at the service. So what also happened at the service? So because, like I said, what the reproductive organs basically is a focus, or is the area of focus for these immediate changes. So immediately after delivery, the cervix is extremely soft, flabby, and then floppy. So it may be bruised and edematous, especially anteriorly if there was an anterior limb during labor. So it looks congested. So this, we are talking about the immediately after following the birth. So here we say that it looks congested and readily admits 2 to 3 fingers. So the cervix also contracts slowly. The external os admits 2 fingers for a few days, and by the end of the and so by the end of week 1, it narrows down to admit the tip of a forefinger only. So the contour of the cervix takes longer time to regain. So we consider about 6 weeks, and the external os never reverts to the nulliparal state. So it doesn't return to the dimple-like shape, but then it becomes a slit-like in shape. So yeah, so the shape of the external os is permanently changed from the characteristic dimple-like os of the nulliparal to the transverse slit.
Ka mata maganan banza ma.
Okay, yes. So complete healing So due to significant or several lacerations, the cervix may appear lopsided. Okay, then completely healing of the cervix occurs in 6 to 12 weeks time and will not regain the pre-pregnant appearance or pre-pregnancy appearance. Okay, all right. So that is for the cervix. Okay. So with the broad and round ligaments, which accompanying the uterus during its increase in size, are now lax because of the extreme stretching. So, definitely, I know you, sorry, definitely, I know that, we have the broad and then the round ligaments. I believe you understand me because yes, you've just done APRS and already with your background knowledge. So I know broad and then the round ligaments. Yes. And so what happens is that they also accompany the uterus as it stretches because they are attached to the uterus. So as it stretches to term, it also stretches along with it. And so immediately following delivery, it becomes lax. Yes, because of the stretching. This accounts for the easy displacement of the uterus by the bladder. So, like I said, within the immediate, so sometimes that's why it's important to understand the physiology. So if you understand the physiology and what is happening, you don't become too alarmed, or you also know how to intervene appropriately. So here, because of the laxity, especially immediately after the delivery, it also takes time to regain its normal elasticity. And so what happens? So because it's holding the uterus, so it's like immediately following delivery, the uterus is more like in a balance. So say a friend is like, so when when the broad ligaments or the round ligament or something that is something is on the way of the uterus, then it shifts it somewhere because the ones holding it is now lax or it has stretched to its limit and it hasn't regained its strength. So it's like it's hanging in a balance until they regain its strength, they regain their strength, and then whilst the uterus also goes down into the pelvis. Okay, so we are saying that this also accounts for the easily displacement of the uterus by the bladder. You know the position of the bladder. And so what happened is that the moment the woman has a full bladder, it displaces the normal position of the uterus. And so you will rather see the uterus being somehow shifted slightly because the bladder is full and is displacing the uterus. Okay, so by the end of the puerperium, the ligaments regain their non-pregnant length and then tension. Yes, so they goes back to their original state. So with the vagina and then the perineum, we are saying that with the initial or the immediate state post-delivery, vagina remains quite stretched. We know that the anatomy of the vagina, and then we also know rugae. And so during pregnancy, it's part of the passage. And so during delivery, it becomes well stretched. And so we are saying that it still remains quite stretched immediately following delivery, edematous, and may have small lacerations or bruises and gapes open at the introitus. So the vaginal rugae, which is the fold, also gradually do or disappear, typically by around 3 weeks postpartum, though they may be less prominent than before pregnancy. In terms of the size, the vagina gradually decreases in size, but may not return completely to its pre-pregnancy dimensions. And then in terms of the tone, vagina has a tone. And so vaginal tone improves over time, but may be permanently altered, especially after multiple vaginal deliveries. Then the hymen also disappears and is replaced by what we call caricular metiformis. So they are this carunculae metiformis is like small tags of tissues. So they come to replace the hymen, and that's what we call it, carunculae metiformis. So, and it is also a characteristic sign of parity. So it's also a characteristic sign of parity. So with the premium, with the perineum, we are saying that similar to that of the vagina, the perineum is often edematous. So as it appears edematous, bruised, and tender, especially if there was an episiotomy or perineal tear. So healing of the perineal, any perineal lacerations and episiotomies typically heal within about 2 to 3 weeks if properly repaired. Scar tissue may form at the site of repair. Then the pelvic floor muscles are stretched and weakened during childbirth. Recovery of pelvic floor strength and tone can take several months, up to 6 months or longer. Then there's also hemorrhoids. So yes, so hemorrhoids are common during pregnancy and the postpartum period due to increased pressure on the pelvic veins. They may resolve spontaneously or require treatment. And so these are some of the complaints too that puerperal mothers do report. Hemorrhoids, suffering from hemorrhoids, and sometimes it can be very painful. And so depending on your assessment, you can tell the woman, or you can educate or advise the woman that, oh, it will resolve on its own. It will resolve on its own with time, or in severe cases, it may require yes, it may require treatment to allow it to go. Okay. So with the hormonal effect, lower estrogen levels contribute to vaginal dryness and decreased vaginal tone, which may persist until menstruation resumes or with breastfeeding. And so this is also an aspect as midwives we need to appreciate. And so sometimes the woman will come with complaint of vaginal dryness and then decrease vaginal tone. And so in case maybe they want to engage in sexual activities, they complain of pain. And so you should be able to know as midwives that basically this has to do with the lower estrogen levels contributing to vaginal dryness. And this is also one of the problems with women in their menopause. Because of the decreased estrogen, they experiences vaginal dryness a lot. And so sometimes they have to apply these creams that contain estrogen to actually help them. Okay, so until menstruation resumes or with breastfeeding. Okay, so there's also increased blood flow. So initially there's increased blood flow to the pelvic area to promote healing. And then over the time, so over the puerperal period, the vagina and the perineum gradually they return to their pre-pregnancy state, although some changes may be permanent. All right, so I keep saying that, so that's why as part of the principles of care for the postpartum woman, or for for the postpartum woman, we need to respect them. That is, apply what respectful maternity care, knowing that individual experiences vary and people, we are all different. The way we experience pain, the way we experience that is issues relating to pregnancy and childbirth is always different. And so there shouldn't be comparisons, but then understanding them. So that's why most of the time, whether some of our this thing days, or if you want to say any this, it will give you
inside.
you could see that basically she's not paying attention. Meanwhile, you are disturbing us. Okay, so yes, so like I said, individual differences. And so that's why we always give ranges so that we know that between that time, at least on the average, we will have some people theirs occurring early, we have some people theirs occurring late. All right. So yeah, so pelvic floor muscles or pelvic floor exercises also help improve what? Our pelvic floor strength. And so what we call the CODeL exercises is very important. We ourselves, one thing is that we need to learn so that we can teach the woman. Okay, so persistent pain, incontinence, incontinence or other problems should be evaluated by the healthcare professionals. So including the fallopian tubes, initially the epithelium of the fallopian tubes was atrophy and cilia disappears. So by the end of the puerperium or by 6 to 8 weeks, it has also regained its cilia and then its strength. Okay. Okay, so under maybe let's run it off here as far as the reproductive one is concerned. For breastfeeding, we will look at it again, looking at the anatomy of the breast and also the physiology in terms of lactation. So as part of, talking about the ovaries, there's a suppression of ovulation during pregnancy. And so during the postpartum, so at the initial phase, yes, or at the initial stages, ovulation is suppressed postpartum due to elevated prolactin levels, especially in breastfeeding mothers, and the negative feedback effect of estrogen and progesterone. Okay, so first time so we look at it in terms of that is resumption of ovulation. We look at it in terms of the mother who is breastfeeding and the one who is not breastfeeding. So in non-lactating women, ovulation typically what resumes within 6 to 8 weeks postpartum. So they resume ovulation early, or ovulation starts early, and then the first menstrual period usually follows after, that is about 2 weeks later. But then in a lactating woman or in lactating women, ovulation may be delayed for several months or even longer. So this depends on the frequency and duration of breastfeeding, especially the night feeding. And also doing what? Feeding on demand. Feeding on demand is very, very important because sometimes, most women will come, or some women comes complaining that I'm breastfeeding, but still my menses have started coming. And that's how they also get pregnant. Sometimes they even get pregnant without even knowing. So what happens is that your question, or the question you can ask them, is how they've been breastfeeding. So whether they've been breastfeeding on demand day and night, especially the night feeding. Okay. So yes, it's most effective at suppressing ovulation. So however, breastfeeding is not a completely reliable method of contraception. So though we have the breastfeeding in terms of the lactational amenorrhea, that is, yes, the LAM method, but then it's not completely reliable because most women, unfortunately, are not able that is, they are not able to follow it strictly, or they are not able to do it as it is supposed to help prevent pregnancy or prevent ovulation. Okay. So with the hormonal changes that occur as far as the resumption of ovulation and then menstruation is concerned. So here we are saying that after delivery, the levels of the estrogen and progesterone drops, or they go down drastically. So as they go down, they gradually increase as ovarian function resumes. And so prolactin levels remain elevated in breastfeeding women, which inhibits the release of the gonadotropin releasing hormone from the hypothalamus, thus was suppressing ovulation. So basically, that's why we say that the prolactin helps prevent or inhibit the release of the GnRH, GnRH, so that suppressing ovulation. All right. Then we have the FSH, and then the luteinizing hormone also from the is initially suppressed by prolactin, but gradually they increases as ovarian function recovers.
Costa. It's a nice thing. So continue. After that, with you. Continue.
Okay. All right. Thank you. Okay. All right. Yes. So I think with the resumption of menstruation between the non-lactating woman and that of the lactating woman, we've looked at it. So once ovulation starts, especially in the non-lactating woman, then menstruation too can occur within about 6 to 8 weeks postpartum. But then with the lactating woman, it delays because of the breastfeeding and the release of the prolactin, especially the prolactin hormone, which suppresses these these hormones that helps with ovulation. That is we have the FH, that is the FSH, and then that of the LH, the luteinizing hormone. Okay. So here I said, being midwives, there are some other things that we need to also take into consideration as far as our care for the postpartum woman or the puerperal woman. So we are saying that while breastfeeding can delay ovulation, it's not a reliable form of contraception. Women should discuss contraception options with their healthcare provider. Then the timing of ovulation and menstruation resumption varies greatly among individuals. And so you can't strictly compare that, as we've already looked at it. And then in some cases, underlying medical conditions like thyroid disorders, polycystic ovarian syndrome can affect ovarian function and the return of menstruation postpartum. So basically, for example, during postpartum, if a woman is not menstruating for a longer period, then there should be some lab tests that has to be run to ensure that all these factors or all these underlying medical conditions are not there. Okay, so since we still have some time left, let's just consider that is the changes, the general changes, or especially with the cardiovascular changes. Okay, yes, Emanuela.
Hello, madam.
Yes.
Please, I have a question.
You said?
Please, I have a question.
Oh, you can ask, but it seems your voice is very far.
Hello, madam. Please, can you hear me?
Yes, so ask your question.
Thank you. Please, about the menstruation, just recently, my client called me and told me that it's 8 months now and she hasn't seen her menstruation.
Okay.
Is there anything I can do for the menstruation she can go? She doesn't want to get pregnant on her way. And I asked her that the baby breastfeed more often during the night, and she said yes. And I said, no, there is no cause for alarm.
Okay.
And for that matter, she shouldn't be worried, and it will come. So
Okay.
I don't know if that was the right answer that I did.
Okay. Okay. All right. Yes, I've heard your question. Yes. So yes. So once, like we said, once she's breastfeeding well and she's breastfeeding her baby well, especially during the night, as we said, and basically, like I said, you should also understand why the night, because sometimes we just, for us midwives, sometimes we just know, oh, okay, if she breastfeed at night, she will not get pregnant, especially more at night. But then you should understand why or the rationale. Anyway, so that aside, yes, once she's breastfeeding well, then she shouldn't be too worried about her menstrual, because like I said, the prolactin will suppress the release of of the hormones that will cause for ovulation. So the FSH, that is, and then the luteinizing hormones. So it will suppress it. So once that is so now that the child or the baby is 6 months, I'm sure she's now going to introduce food and all that. And so feeding will become irregular, especially breastfeeding will become irregular. So she should give herself some time to see if the menstruation will come. So that's why I said that if the menstruation is not coming, there may be also, maybe if normally we look at it up to the first 12 months. And so if still ovulation is not coming, that is where we have to do underlying checkup to see if there's no underlying problem or there's no underlying issues. And so, yes, I think you did the right thing. Yes, she shouldn't stress or she shouldn't worry about it once she's breastfeeding well. But then when she stops breastfeeding, or now that she's about to introduce other food to the baby, then definitely the breastfeeding will not be much or frequent as it used to be. And so definitely it will cause the prolactin to naturally drop. So once the prolactin naturally gradually goes down, then the FHS, that is the follicular stimulating hormones, and that of the luteinizing hormones, they begins to rise. So once they rise, she should expect she should expect ovulation to occur and then subsequently her menses to occur. Yes, but then the other thing that you can also help her with, I don't know, that's why we also counsel them on family planning. So immediately, in fact, for WHO, ideally, you don't even allow the woman to go home. Before discharge or as part of the woman's discharge plan or education, you should counsel her on family planning so as to remove all these stress, because stress also affects lactation. As we go through lactation, you will realize that stress affects lactation. And so to remove her mind, sorry for using this tree brothel, but to remove her mind from wondering whether she's going to get pregnant or not, you can counsel her on family planning. so that she can start with the family planning, especially the ones that are safe. We will do that. We will look at that one briefly to know those that are safe for doing breastfeeding, so that she can engage in those ones whilst she is still breastfeeding, so that she can, whenever she's ready to have another child, she stops she stops the family planning. So yes, I hope I've answered your question. Okay. All right. So our time, okay. So yeah, so do well to also try counseling her on family planning and
She
advice.
said her husband doesn't support family planning.
Oh, okay. Okay. All right. So like I said, then she should continue breastfeeding well.
And
Okay.
so I told her that if it reaches 1 year and still the message hasn't come in, that's when there will be a call for alarm.
Yes.
So
Yeah.
any moment from now, she should expect to
Yes.
from now
Yes.
to 1 year.
Okay. Yes, exactly. Yes. So once it's maybe like after 12 months, then she can be doing some other test to rule out any underlying factors if it's still not coming. All right. Okay. So I don't know, because of our time, do anyone also has any question or addition or comment? Okay. So, okay. Yes, Rebecca.
Please, I wanted to find out. You said pertaining bleeding, those who go through CS bleed more than those who go through SVD. And I
Yes.
wanted to know whether it is because of the cuts, the insertion that makes the bleeding higher than the SVD, or they bleed per vaginum.
No, you mean the incision that is being made?
Yes, please. Is it because of the incision that makes the bleeding more than those who go through the SVD?
Oh, okay. Okay. All right. Okay. So yes. So this is Rebecca's question. But I gave it to Gifty, or yes, I gave it to somebody asked on the platform, and I said she should go and read so that next week she tells us why, yes, it's Grace rather, why in CS bleeding more higher than in HPD. Anyway, we can discuss it. Yes, any idea? Maybe we can use a few minutes to. Yes, hey, Akraben. Because my know about the bed didn't all answer the question. Anyway, yes, Mercy.
Yeah, sister. I
Yes.
think with the CS and SVD, the CS, the SVD, it goes through process,
Okay.
but with the CS, there's no, maybe it's booked one. So the uterus does not contract as compared to the SVD. That's why they intend to bleed more. Because I've done CS, I know the difference.
Okay.
Per the CS, the uterus does not contract much as the SVD. That's why they bleed more. That's my opinion. Thank you.
All right. Okay. Thank you, Mercy. Yes, who again? Who else? Before I come in.
Hello, ma.
Yes.
Doctor, please, I think there is more bleeding during the CS as compared to the SVD, because normally during the SVD, normally there is no cut of tissues. It's just the baby coming out of the uterus, and then our only bleeding is going to be from the uterine lining, and maybe when the placenta detaches, then there'll be bleeding from there. But with the CS, there's going to be all that will happen like in the normal delivery, the detachment of the placenta and all, but them cutting through the tissues too, they'll cut and then there'll be more bleeding from that part too. So I think that is the cause.
Okay. All right. Yeah. So, okay. Oh, okay. I think somebody's hand, maybe when. Yes, Ellen. Ellen, please, do you want to also add
Add
that?
to what my sister said.
Okay.
Yes, please. I'm adding up.
Yes, please. Okay.
I'm adding to what my sister just said.
Yeah.
During the cesarean section,
Okay.
there are some cases when after opening, so performing the adhesiolysis, when you want to do away with the adhesions, the person might bleed. That's why when you consider the definition for postpartum hemorrhage, it goes for 1,500 for
Oh, Ellen. Oh, okay. It seems
cesarean
okay.
sections, which is an average amount. It doesn't mean the person is going to bleed. So averagely, we assume that those who undergo cesarean sections bleed more than those who undergo SVDs because of some adhesiolysis and other bleedings from the.
Okay. All right. So, yeah. So I think Ellen has made her point. And so thank you so much for that addition. Okay. Yeah. So lastly, we will listen to Jennifer.
Yeah, sister, please. I also think that since we are talking about PPHN, PPH is like bleeding after delivery. My sisters has made their points, yes. But my point is, since there has been a cut on the uterus, yes, the uterus cannot like contract effectively because of the
Okay.
wound that has come. So there has been an alteration. That is
Okay.
why after delivery they bleed more than, like they tend to bleed more than those who went to the
Okay.
SVD. Like that is what